Sir, की slide? Okay. Sir, Dr. Sitaraman, sir. Sir, Senior Professor Pediatrics, SMS Medical College, Jaipur. Sir, established the first child developmental center, established the first human milk bank in State Medical College, and national tenor of APLS and NRP. Sir, sir has honor with the WHO Fellowship and the Commonwealth Fellowship. Please, sir, come and proceed panel discussion, that is the neonatal survival, combined responsibility of obstetrician and pediatrician.
Okay. पैनलिस्ट के नाम और वो कौन इंट्रोड्यूस करेगा? आप करोगे? आप कर दो. आपको है ना?
सर मुझे एक्चुअली वो आपके पेपर दे दीजिए, इससे कर देता हूँ.
इसमें तो नहीं है सर.
नहीं मैं बोल दूँगा सर, कोई दिक्कत नहीं.
डॉक्टर काबरा.
So, our panelist, I invite to Dr. Nandakishore Kabra, sir. Sir, Director, NICU, Surya Hospital, Mumbai. Please, sir, come on the dais. And sir will answer from neonatology and newborn care. Now, I invite to Dr. O.B. Nagar, ma'am. O.B. Nagar, ma'am. And ma'am is from, madam will tell about the obstetric problem, how to, that we will have the optimize newborn survival. And Dr. Ravi Sachan is professor from UCMS Medical College, and sir is taking care in NNF India perinatal chapter. Sir will tell about what is the policy about NNF India. And Dr. Anil Agrawal, he is here, and shortly that he will from UNICEF. So within 2 minutes he will become, sir. And Dr. Rekha Gupta from genetics, and she is, please Dr. Rekha Gupta, please come and join with us in panel discussion.
Thank you, Dr. Mahendra. So we have a fairly, galaxy of panelists with us, and as Mahendra has already introduced all of you, my questions are fairly generic, but I would welcome some of the questions which you all would like to ask these panelists in certain issues. So they can be, as done earlier, you can write it down on a slip of paper and we can push it off. And basic theme of the philosophy of this panel discussion is to see how we can have a normal, healthy newborn and how it should be followed up. Every field of medicine has to have some integrative and communication between 2 or 3 aspects of medicine. And this is one of the areas where we have a very close association with the Department of Obs and Gynae. So we have one expert from neonatology, one expert from Obs and Gynae. Dr. Nagar is also a professor of Obs, and she has been representing the interests of women, especially from her organization of FOXY. And of course, Ravi is also, he's combining both of them, taking both neonatologists and FOXY together for a perinatal meeting. And Rekha, of course, is going to tell us something about how the newborns are to be, unka jo na janam patri, dekhne ke liye. Okay, so I'll shoot off my first question to Dr. Kabra. Now, I would want you to enlist the neonatal outcomes which are influenced by care during pregnancy. Most of the time, you have these issues. Frankly speaking, those days are gone where there was a constant tussle between the obs and the neonatologists, and the blame game used to start. Now, we have to have a very collaborative effort, and this panel discussion is just to project that feeling that we have to work together to get our best outcomes. So the first question directed to Dr. Gabra. Yes.
So basically, the whole aim of the pregnancy is to have a healthy baby. So if you have good antenatal care, it will have direct impact on morbidities and mortalities. And the things that are of interest to us is preterm birth, low birth weight, and growth restriction. So if we look through the literature, and there are systematic reviews of observational studies, also some moderate quality RCTs, which shows that definitely there is impact on the rate of preterm birth. And preterm birth indirectly, like, if you have a preterm baby, there are going to be a lot of morbid conditions. So by preventing preterm birth, by preventing low birth weight, by preventing SGA, we are going to reach higher dividends. Take an example, if you have pregnancy-induced hypertension, and if this mother is properly managed, you are less likely to have a preterm or IUGR, and you would be able to prevent complications of that. If you have a mother who is HIV positive and we take her good antenatal care, we would have a healthy baby. If you have a mother with anemia or other medical disorders, or if you have a mother who has a diabetes, or you have a mother who is going in preterm labor, and by giving antenatal steroids, you are going to reduce the risk of RDS, you are going to reduce the risk of mortality, you are going to reduce the risk of NEC, you are going to reduce the risk of IVH. So there are multiple benefits, and also like you have got opportunities to interact and educate the family, so on and so forth.
So, Dr. Nagar, now you have found that our neonatologists have these concerns. He has only listed a huge list of mental conditions which are going to affect the newborn. Now, I want you to tell us, as a part of an organization, as a major OBS organization, what are the basic organizational guidelines from your own organization, which is...
Sir, we were just discussing...
which is, especially targeting towards the outcome of fetus.
Yeah, thank you, Sitaraman sir.
Just a minute. Oh, I welcome Dr. Anil Agarwal from UNICEF. He is the one who is going to tell us what we are going to do ultimately in our community. Yeah.
Sir, the stress, as Dr. Kabra just said, that the mainstay is a good antenatal care. Now, how you define a good antenatal care? If you go by Indian guidelines, they say just 3 visits is enough. At least 3 visits should be there. Then there are some textbooks which say 3 is fine, you can do with 5 are better. And then there are people who will say first visit as soon as she comes to know that she is pregnant, and even before that, when she is getting married, because there is a definite role of pre-genetic counseling and knowing about genetic diseases nowadays. So nobody is exactly sure of what actual good antenatal care is. So what we have done in our institution, we have an antenatal card for that, and we advocate at least 5 visits. First visit as early as possible, second in, at the end of the first trimester, where we can look for neural tube defects and other congenital malformations. Nuchal translucency can be done. We can screen the mother for anemia, because as sir was saying, and as you also know, sir, and you have been teaching us since long, that prematurity is one thing.
In your surveys, how many mothers do you actually feel that are anemic to the extent which has compromised?
That is what I am coming to. Prematurity as per se is a cause, the cause basic lies in a simple anemia, which predisposes her to asymptomatic bacteriuria or urinary tract infections, which is the major culprit for, say, premature deliveries, and which is a major culprit again for neonatal deaths and lots of burden on your neonatal unit. So we do at least 5 visits in our institution, where we check for maternal weight, maternal infections, hemoglobin, and blood group, because blood group, again, you are catching hold of RH incompatibilities. You are giving, maybe if she is RH negative and husband positive, you can we are giving anti-D as a routine, and it is free of cost in government setup. Then PIH, that is another one culprit. Now there are so many tests by which even in first trimester you can point out that this patient is going to develop PIH. So that is a part and parcel of our say antenatal checkup. Till now, we were just doing serum VDRL, HBS, HIV testing, which was mandatory because that also aids to, supposing she is having hepatitis, there are chances that the baby will come out low, and we tell our pediatricians that immunoglobulins have to be administered to her. So it goes hand in hand. Pediatrics and gynae, always obstetrics goes hand in hand. Then nowadays we are screening every patient for diabetes mellitus. There is a DIPSI criteria, definite DIPSI criteria by which we are screening these ladies for diabetes, which was not the previous protocol. This has been added recently. Now another disease which we are sensitive to now, and we have made it a part and parcel of our antenatal, that is the thyroid disorders. So as a routine checkup, we are also adding thyroid TSH, then maternal weight gain, then the maternal height, because that also has a bearing on it, then any chronic illness the lady is having, then this whole thing, how things are, some institute might be taking, the other might not be taking. So to make it as a general consensus, we have added all these things in our antenatal card. Okay. So nothing can be missed. It is just like a checklist, and everybody, and there's a high risk tag also.
This antenatal card which you say is fairly uniform throughout the country from your organization?
Yeah,
or
nowadays
is it
we are
only
having,
for your institution?
No, we are having a Mamta card, which is universal for, I believe, whole of India, because we are having Janni Suraksha Yojana, and it is a very colorful, unfortunately I didn't get one, I should have got it. It has right from the antenatal till the patient is discharged, and even the discharge ticket is inside that.
Okay.
And it covers everything.
Just trying to...
Even the immunization part is over there.
I am quite convinced about the kind of cards we tend to make and distribute among all of our this thing. But in your basically, let's have a very frank opinion whether actually the cards are filled to the same extent as it should be done.
Yeah, sir. I will like to give an input. I was at Delhi some 5 years back, and there was Dr. Sikdar. He is the family welfare director, family welfare at central level, and I had a real fight with him. He was good enough to provide us with counselors for HIV. Now those ladies who have been given to us for HIV counseling, and then we are having 2 family welfare counselors also. Now we have put them to good use. And what they are doing is, even if the doctors are busy, they just see whether all the columns are filled or not. Maybe it may be hemoglobin, maybe BP. So those people, and even us, at every antenatal visit, we are very particular that all the columns are filled up. And one-step test for hemoglobin and HIV, HBS, sugar at one point only. Like it is a part of good governance that we are incorporating in our system. So that is done one time only. As soon as the patient comes, whatever time she comes.
Actually, that's quite informative. Just a thought appeared in my mind. There has been now a trend for say optional C-sections or elective C-sections, and also the time of gestation when we want to intervene. First to Dr. Kabra, as a neonatologist, what gestation age you will be extremely comfortable in if there is an elective delivery to be conducted?
So the guidelines will vary from place to place, and what we do in our unit is that we have approximately 150 babies who are less than 1 kilo admitted every year. The survival at 24 weeks is 50%. So 25 weeks and above, if it's obstetrically indicated, justifiable, cesarean section, we are okay. 24 weeks, generally it's a joint counseling that is done.
I want the higher age group where the child is reaching term, but sometimes it may be 36 weeks, 37 weeks, 38,
okay, so your
39.
question is that the other gestation. Now more and more recent evidence is come that generally you would not do elective cesarean section until completed 39 weeks.
39 weeks.
Because even at 37, 38 weeks, you would have issues that we would create for the babies in terms of respiratory distress, in terms of transient tachypnea, requirement of NICU stay. So if the pregnancy is going fine, there are no complication, no elective cesarean section if mother is not gone into labor until completed 39 weeks.
Yeah, because there is a general feeling that any child below 39 weeks, we have some problems like late preterm babies. They look good, but they have their own problems. Dr. Nagar, how do you feel? Is there any guideline that would you have a cutoff level for any mother wanting to go for elective, or you are your?
So the cutoff is for the pediatrician. They tell us that you have delivered this baby very early. Our indications and guidelines are different for different diseases.
Yeah.
Like 39 is for everybody.
Okay.
Who is not suffering from maybe fetal-placental insufficiency. Like in cases of pregnancy-induced hypertension, supposing she comes with eclampsia. Now, and she's around 34 weeks. So we would like to terminate her by a C-section for maternal indication as well as fetal indication. Maternal, we have to stop all the fits, which can be life-threatening to her. It might cost her life.
They are
the lady first.
Medical conditions where you are likely to intervene.
Yeah.
But in normal pregnancy which is going on, and sometimes
Normally 39 weeks beyond,
we would
only
like to
we
do
touch
that.
her,
Wonderful.
not before that.
So we go on a consensus on that. Dr. Ravi has been doing quite a lot of mixing both the fields of neonatology and finding out how to go about it. I would like to ask you that the basic concept of perinatal care and how the organizations like Foxy, NNF should all join hands together to deliver a common, agenda for them, especially taking care of the fetus.
Okay. So thank you, Dr. Sitaraman. This is just to inform you and everybody is here. The concept of perinatal care in India is not very much new. It is very much, available there only, but now it is the government of India is moving a little bit in a more pace. So since we remember that in 2005, once it was launched a National Rural Health Mission. So later on it becomes a National Health Mission in which the Janani Suraksha Karikram, JSY and Janani Shisu Suraksha Karikram was launched. That was, I think, it was the milestone in the neonatal or perinatal history in our country. So in fact, these two health programs, they have tremendously increased the workload, or they just shifted from community or home-based, what the delivery was earlier taking place at home. Now they're being shifted to the institutional deliveries. So definitely the concept is not very much new, but as we are advancing, later on the government of India just started, just like Dr. Nagar told, antenatal visits, and the program is called Pradhan Mantri Surakshit Matratva Abhiyan. So it is already being in there, and it comes every month, 9th of every month. So it is specifically meant for the second trimester or third trimester mothers who are visiting the antenatal clinics. They are specifically examined in that point of view, for an antenatal care point of view itself. So, and another lot of programs are there, like Dakshta program. Recently it has been launched. Dakshta means the
Skill.
Dakshta means the person who attending the deliveries should be daksh, means
Skilled.
in attending the deliveries, or should be daksh in the taking care of resuscitation of a newborn or in the emergency obstetric services. So definitely, in the recently you must be here. There is a launch of Laksh program, which is dealing with the improvement in the delivery room practices as far as maternal neonatal care. In emergency means maternal OT and labor room. So it is not very much new. Now we are progressing in a very fast pace because it is now that it is considered as a need of the hour. Because as we are advancing, the technologies are being advancing. We have got a lot of fetal interventional procedures are being done. So it is now moving a little fast. So as if you are saying it is not a new, definitely it is now coming up in a big way. So as a partner, Neonatology Forum, being this body is advisory to the government of India, and definitely we are advising in terms of neonatal care to the government of India time to come. And one of the program is facility-based newborn care program. It was also launched with the same intent to decrease the neonatal mortality rate. Specifically, if you are looking at the trends in the neonatal mortality rate. So if you look at the under 5 mortality rate, maximum mortality is being for infant mortality rate. If we come to the infant mortality rate, it is the neonatal mortality rate which are more. And if we come within the neonatal period, it is the first, what we call early neonatal period, that is within 7 days, which is included in the perinatal period. So it is. So it
Dr.
is.
Ravi, one concern I have is practically the baby is born is absolutely fine, but I am very much concerned over that stillbirths.
Yeah.
That's the area where no one seems to be, sort of having a responsibility, because
Yes,
ops
yes,
people
yes.
say we had to carry it out, but
Yes,
something
yes.
happened.
Yes,
Now, what
yes.
has happened, we don't know.
Yeah.
The neonatologist says something happened, we don't know. So
Yes,
where
yes.
does this group of stillbirths,
Yeah.
who is actually, and how is it going to be tackled?
Okay. So
How
sir,
should the stakeholders participate in lessening that burden?
Yes, sir. You are very rightly. It is always the bone of contention between pediatrician and obstetrician. So, and who will, mortality will go under to which accounts. So, this is really pointed out well. Stillbirth is, as far as the India Newborn Action has been released, India Newborn Action Plan, it means targeted to decrease the stillbirth rate less than, in a single digit or less than 10 by, 2030. So the problem is why the stillbirth is there. So if we have means antenatally counseled properly, if we have investigated properly, if we talk to the obstetrician why it is going on, and the neonatologist to get stakeholder as a who will be responsible. I think the both has to sit together and discuss why this is happening, what has happened, and along with the mother and or the parents, so that we can discuss this has happened because of this. And it is very unfortunate that in our country, some of the policy, it's something gray area is there. The policies are also not clear. So that is why I think the problem is occurring.
So
as far as
see,
the-
that's what I exactly wanted. Both the stakeholders for this are both the organizations.
Yes, definitely.
Now this field is where both have to put in their input to get something now.
Yes.
I'll ask Dr. Agarwal in this, Anil. See, you have heard all the specialists now. You have heard this thing. Now, all I have said that, yes, there should be a collaborative effort. The government has also found many of those programs, Lakshya is there, Daksh is there, and everything there. But right at the community level, you have been working a lot with community workers. Now, you tell me at that particular area of community level, how does this actually translate into a good outcome giving? How do the practices really, or do you say there is some lacuna, or our stakeholders basically should modify some of those issues in this?
Yeah, so thank you very much, sir, for that question, and thank you for the advice which we have received from the experts. Regarding the community level intervention, we already have the guidelines and the tools, and everything is possible and available now. With the coming up of NHM, things have become so easy in terms of availability of infrastructure, supplies, equipments, everything is available. It's about the mindset and the processes being followed. Just to share some numbers, what happens every month in the state of Rajasthan, almost 66,000 MCHN session, maternal child health nutrition days, are being celebrated. And these days are piggybacked on the immunization sessions, which used to happen earlier. And now these are integrated sessions where antenatal care services are provided, care to the sick children is also supposed to be provided, but they are not happening in the sense they should have been. In terms of privacy, if we look at in those sessions, we are still lagging behind. It's not that the resources are not available, but the mindset of the people and that chalta attitude is making more hindrance rather than actually having a standardized protocol or the norms. So the weakest link right now is the support to supervisory mechanism. People are not being supervised and monitored, and that's why those questions are not asked. That's why antenatal care gets lost, or in terms of the quality is not delivered. Rather, number remains, like how many TT you have got. So that's being monitored.
We take that message that working in that, both organizations have their own agenda, they have their issues, they have the recommendations, but you feel a human factor is which is not causing the implementation. Now, as a representative of NNF and Foxy, I would, and prenatal care, I would definitely like you all to comment, how can you overcome this human factor of delivering services? Yeah, all three of you can address this, because you both from there and you are of course prenatal. Or you can address jointly
So
also.
ladies first again.
Okay.
Otherwise also I would have spoken, sir. So, sir, I will want to address this one to, the basic thing is, when do we call a pediatrician? After the baby has been born?
No, I'm not talking only on the pediatrician or the neonatologist, this thing, I'm talking like generalists, for example, a community health worker also.
Community health,
Because,
yeah,
you know-
exactly. That is what I just want to say. Whosoever is getting the patient delivered, it can be a community health worker, because nowadays we are having Asha Sayogini, we are having health visitors, and even they are trained into the art of delivery if the condition is such. So, sir, what happens, when do we call a pediatrician in picture? It is when the baby is already born, it is an SB. Now we'll call and ask him to take the responsibility, say, I tried to resuscitate, the fetal heart didn't come, there was something in the lungs, the baby was low birth weight, like that. So how I feel is, if there is a patient, we have taken a proper history, we have filled in all the columns according to the checklist, by and large, because there the number is 10, as Dr. Hakan was just saying, that we have to reduce it to 10, we can never do it 0. So leave alone those 10%, but otherwise there are many things which can be counseled to the patient, like a simple thing as a daily fetal movement kick count, that the lady herself can do. Because many a times they will come without fetal heart, where the baby is lost some 7 or 8 days before she comes to us. So in conditions like diabetes mellitus, pregnancy-induced hypertensions, gestational diabetes I just told you, then other such conditions, or there is a history of previous SB. So these type of patients, we can have a talk with the pediatrician prior to the delivery itself, and counsel the patient of such consequences.
So you mean to say there's the interaction between the both
interaction
stakeholders should
prior
be
in the
throughout-
antenatal period only.
Okay.
Because there was one patient, I still remember, and many of us do it like that. The umbilical artery is one, vein is one, and artery are two. Sometimes we see the reverse. And the best thing to do is either to send the patient directly to the pediatrician or a geneticist.
Okay. We will take, Ravi, any comment on that? How the stakeholders are going to actually ensure that human factor does not hamper the delivery of services? Like what Anil pointed out.
Okay, fine. So see, what that means, theme of this is whether it is obstetrician or pediatrician, everybody is, target is to have a healthy baby and healthy mother. So we have to think in that line also. So who is coming into the picture, who is not coming into the picture, I think it's really a little debate should not be there. But as far as is concerned, both of us, neonatologists and obstetrician, has to be in the same page. They have to discuss with each other, whether it is NNF or FOXY, this issue has to be resolved. What is what we call a human factor? Probably this, am I right? So these two things has to be collaborated. In terms of formulation, see, our medicine, our field is, definitely there can be some lacunae there. There can be some gray area in both the fields. But once we are moving ahead, moving together, apart from keeping our individuality differently, let's focus and let's talk about the healthy baby and healthy mother. So in this regard, I think when we are coming together, so once we are moving together and ultimately targeting the healthy baby, I think the human factor should not be come into the effect.
Dr. Kabra, you had a lot of experience with training people and everything is there. But do you feel that where exactly this is of that schedules, human factor which influences your implementation of any program, do you envision that there should be some kind of a way we can circumvent that? It is a difficult proposition, definitely, I know. But how do you feel the human factor of delivering services can be taken? Is it you would like to give some kind of incentive to them, or you would like to sort of, why do you have such statistics which go very slowly on improvement side? And when you find that some of these things are put into practice, there used to be a remarkable change, and somehow then some changes are not at all remarkable. That means the program implementation is the only thing which was causing problem. Do you think can we do anything about, you have been training so many students, so you will know.
I think we need to motivate people around us, and we ourselves need to remain motivated.
Motivation is that issue, definitely, but in a sector, what exactly in your, because you have been working a lot in private sector, how do you ensure that people get that mindset that yes, I have to do the needful? Government sector, I'll ask Anil on how to go about it, but because they have other ways of asking a government doctor to do their job. But in a private sector, how do you do that? Because you have quite enough interaction with your ops colleagues also, isn't it? Yeah. Because you are handling, because the second question was directed towards you in that particular area, that when you have, you are handling so many very premature babies, then you have certain points that my ops person should do, 1, 2, 3, 4. Yeah? Then I'll be very comfortable in handling my primaries.
Yeah.
So that's the second question. So if you are not comfortable with that human aspect, I'll switch it over to Dr. Anil. But before that, you can answer this question, whether how premature babies, very severe premature babies you are handling. And you find now with the evidence-based medicine, that in these particular babies to get the optimum survival, I would want my ops people to do these things alone.
Okay, so your question is like, for preterm babies, how can we prevent prematurity and what all things can be done? By and large, the rate of prematurity in India has remained around 13%. And there was a beautiful article in Lancet in 2012 that talked about what all things can be done to reduce the prematurity. There are two ways. One is primary prevention and one is secondary prevention. Primary prevention is you are assuming that everyone is likely to deliver preterm and does not have a history of previous preterm delivery. What all can be done? So first thing that you would do is that good antenatal care, monitoring of the weight gain during pregnancy, optimization of the weight gain, supplement with nutrients like iron, folic acid, calcium. If there is history of substance abuse, smoking, prevention of that, education and care of that. And then suppose this pregnancy is being happening through artificial reproductive technologies, then we see that these IVF specialists will put 2 embryos, 3 embryos. So if you have multiples, the risk of preterm delivery is higher. So rather than putting 3, 4, you put maybe 1 or 2. So that is primary prevention. Secondary prevention meaning already you have a history of previous preterm delivery. So in second pregnancy, the risk of preterm delivery is going to increase from 13% to 25%. So in such situations, you would think about whether the cervical encerclage would help because the cervix is short. You would also think about giving progesterone for continuation of the pregnancy. And if there is bacterial vaginosis or asymptomatic bacteriuria, you would consider antibiotics. Also consider anti-inflammatory medications. Controversial role of omega-3 fatty acids. And then there are preterm birth prevention clinics. There is empirical evidence that suppose I do one particular thing repeatedly, I would have a better result than others. So if you, in your own institute, if you have somebody who is running, somebody who had previously preterm baby and she gets shifted to that clinic so that she is closely monitored, and then twins, triplets and multiples will need special attention. So this is a comprehensive management plan. Estimate by World Health Organization is that if suppose you just take good nutrition care, antenatal care, cessation of smoking and cervical encerclage, you will reduce the rate of prematurity from 13% to 5%. Significant reduction.
And Dr. Obi, you heard what Dr. Kabra has said. Give me just 4 or 5 points on what your organization has been able to make a statement for preterm labor, preterm delivery, which you say that this has to be done for have an appropriate preterm delivery outcome.
Sir, there are certain conditions like polyhydramnios, twins, short cervix, some surgery over the cervix like Manchester operation sometimes done. So in all those conditions, we have to look at the cervix And as sir rightly pointed out, there are many ways of doing now tightening of os. The common procedure can be done vaginally. Now we are going in for laparoscopic tightening of os, that can be done. And major issue is of not only asymptomatic bacteriuria, the changed vaginal flora of the upper 1/3 of the vagina. A simple act of coitus can deposit the bacteria which are down below in the lower 2/3 part of the vagina to high up. And how that is going to work is, if they will ascend into the cervix if the plug is not there, the cervical mucus plug, and they start a little bit of chorioamnionitis in the lower part of the membrane. That is a very crucial thing. Simple bacterial vaginosis, that is a very major thing which is causing lots of PROM. And a simple drug like clindamycin given vaginally, that cures the situation. So these
So,
things can be looked.
do you once you have made such intervention, do you communicate these things to
Yeah.
the neonatologist
Yeah.
or the person who is attending the?
See, not the neonatologist, but when the patient is coming for antenatal checkups, we ask her either for abstinence, or if she has already acquired some sort of an infection, then given simple vaginal pessaries helps.
Because our neonatologists get very afraid when the mother is actually infected and the baby is likely to be highly infected by chance when it's born. So
Yeah.
they are usually quite
We
concerned.
communicate that to the, we do get a CRP done, C-reactive protein. Supposing there is preterm PROM, then we communicate that to the pediatrician, that look, 12 hours have passed, 18 hours have passed since she has had a history of premature rupture of membranes, and you can suspect some kind of infection in the neonat. It is preterm also, and it has a tendency to go into infectious status. That is one thing, sir, which we are very cautious about. But otherwise,
Ravi, you have
nowadays,
seen-
one
yeah,
more thing,
yeah.
sir, some medications, newer medications have been added into the obstetrician's armamentarium. I would like to tell about a drug. It is atosiben. Supposing she has already come into premature labor, that can very well be prevented by this new wonder drug, because as of late, you remember isoxaprine hydrochloride, it has been US FDA banned. So now this drug has come and come to stay with us, and it is a very good molecule to prevent premature labor and
But
premature.
does it affect the newborn? Does it affect the fetus in any way?
Yeah.
No, it may prevent a premature labor.
Yeah.
But does it have any effect on the fetus?
No effect on fetus. It is quite safe, sir.
Okay.
That can be given, sir, to prevent premature labor. We can halt the labor process as
Wonderful.
such.
So we
And,
have, not only from that point of view of taking care of infections, which you have been repeating, I
Yeah.
think in the morning also there was a statement by Dr. Kabra himself that infection is one of the things which can precipitate the whole issues. Now, Dr. Ravi, can you tell me that, have you ever screened the protocols submitted by, both organizations like FOXI and NNF separately to see if there is any disparities in our evidence-based care?
Sir,
No, because we speak our own music and the other organization
okay,
will say-
fine. So as I told earlier also, there can be some, some gray, medicines are very unpredictable. There can be some there can be some gray area in the policy makings. But if we are, little moving ahead in, above all, here is the matter of neonatal survival. The matter of neonatal survival, when suppose we look at the, what the guidelines of FOXI said or ACOG recommends or the NNF recommends or the whosoever the recommending bodies are, everybody, if you look at in a broader perspective, still there can be a potential best practices can be practiced, So it is apart from what the guidelines says, ACOG says, prematurity. I don't think, sir, I am seeing the other sides of coin. If suppose there is a lack in the policy making, so we can have own generation of evidence. Now everything is now evidence-based, as you said, right? Evidence. We are living in the era of evidence-based medicine. So if at all evidence not there, let's generate. Because what the things are feasible for the ACOG is recommended may not be feasible in our country. Our neonatal population is entirely different from the Western world. So, so I am saying like this: if you don't have any data or if the policies are something which is not feasible in our country, we can generate our own side.
Okay.
We can generate our own evidence, and that can be feasible and applicable. We can definitely have a potential best practices, and that we can we can replicate in the model, or we can generate our evidence itself. And so whether it is a FOXY or it is NNF, that can be in a major policy can be formed.
Sir, AI
I'll cite one example. See, as a neonatal NNF protocols and everywhere, they will definitely say that the child should be delivered on abdomen, and breastfeeding should be initiated within half an hour. But that the whole concept of delivery on abdomen, at least our training process has been there. But does it does your organization also feel that should be the practice and should be adopted? Because I still find it is not being adopted universally. Though now that's one of the evidence-based we feel.
Yeah.
But do you have any constraints or logistics reasons where it cannot be practiced?
So should I respond first?
Yeah, sure.
Okay, so let me give you an example in my own hospital. Right now we are delivering, I'm talking quality improvement is also what the Lakshya is going on. If it is Lakshya or any quality improvement procedure